गुड इवनिंग सर। हाँ सर, अब ज्वाइन कर लीजिए सर, सेम लिंक पे सर। नहीं सर, आपकी फोटो नहीं आ
Good afternoon to all the attendees. I welcome you all to Stethify Episode 4, an official podcast of IMMSN UP. Our guest speaker for today's event is inspiration of people across ages, Dr. Naresh Trehan sir. I would like to thank and welcome State Convener Dr. Rajneesh Raj and our State General Secretary Dr. Rahul Anand for making this event possible. Furthermore, I would like to thank our State Co-Convener Navya Jain and our State Joint Secretary Dr. Rakshit Gupta, Sakshi Singh, Lakhan Prakash Gupta, and Rohit Maurya for having our backs. I would also like to introduce and thank my team, Harsh Rai, Jay Pasi, Sneh Sahani, and Arjeet Bansal for their hard work, motivation, and constant support toward making this event successful. Sir will be joining us soon. I would also like to welcome Dr. Arvind Swamy, National Convener, IMMSN, Dr. Simran Kalra, National General Secretary, IMMSN.
Hello.
Very good afternoon, sir. Very good afternoon, sir.
Good afternoon.
Anji.
A very well-known face on our screens now. On behalf of whole IMMSN team, I welcome Dr. Naresh Trehan sir, Managing Director and Chief Cardiac Surgeon, Medanta-The Medicity, a 1,500-bedded multi-super-speciality institute which offers cutting-edge technology and state-of-art treatment facility. Hello. I request everyone to please turn off your mics. We have reached the moment.
Everyone, please turn off their mic.
Turn off your mics. Dr. Naresh Trehan sir, Managing Director, Chief Cardiac Surgeon, the Medanta-The Medicity, a 1,500-bedded multi-super-speciality institute which offers cutting-edge technology and state-of-art treatment facilities at an affordable cost. Sir also founded the Scott Hurt Institute and Research Center, where he was Executive Director. Scott was conceptualized, created, and managed by Dr. Trehan sir from November 1987 to 2007. Sir have received many prestigious awards, including Padma Shri, Padma Bhushan Award, presented by Government of India. He was President of International Society for Minimally Invasive Cardiac Surgery and have also received doctorate degree from 3 prestigious universities. Thank you, sir, for taking out some time for us from your busy schedule. I would also like to thank our National President IMMSN, Dr. Arvind Swamy, and National General Secretary, Dr. Simran Kalra. Our organizers, Dr. Rajneesh Raj, IMMSN UP State Convener, Dr. Rahul Anand, IMMSN UP State General Secretary. Sneh Sahani Arjeet Bansal for coordinating, Harsh Rai Jaypasi with Abhinay Srivastav, myself, for coordination. Once again, I welcome you all to Stethify Episode 4, an official podcast of IMMS in UP. Let's begin with the episode. Shall we start, sir?
Yes, of course.
Our discussion is divided into 3 parts. Initially, we will be discussing about advanced imaging techniques. Next is the need of hour. We will be discussing economic challenges in medical sector and discussion on science behind broken hearts in the last. I, Abhinay Srivastav, will be hosting the first segment, Advanced Imaging Techniques. We would like to start with a very foundation discussion, sir. Invasive and non-invasive are the 2 techniques of cardiac imaging used. What are the difference and also what are the scenarios in which each one is preferred, sir?
So if you take the full spectrum, like you said, non-invasive, we start with first. So you're all familiar with the age-old ECG, which itself is important tool in the sense that if you learn how to read it, it gives you very valuable information. But unfortunately, it is a recorder of history. It is not a predictor of the future. So ECG is a good tool to see what happens. And if there are any existing conduction defects which may at a later stage lead to trouble. So that is a diagnostic tool first. Then if you want to take it to the next step, is the dynamic ECG, means that you have a choice of either stress echo, where you can do a treadmill test or a stress echo. So treadmill test is dynamic by itself, will give you only changes in the ECG under stress, and then the protocol will take you to a certain height, depending on age and your weight and stuff like that. So then you will then know, it's known as the Bruce protocol, which is the most popularly used tool for doing stress ECG. To make it even more accurate, you can add stress echo with it. So there now you have 2 modalities. One, you're doing the stress while you're recording the ECG, but also you are seeing the wall motion of the heart, what happens to it when somebody stresses. So incrementally, the accuracy of your diagnosis increases from non-dynamic ECG to dynamic ECG to combining it with stress echo and dynamic ECG. These are all non-invasive techniques. In addition to that, now we have what we call a stress thallium, which has got many isotopes you can use. Again, it's a stress test, but you use a dye, nuclear dye, to actually stain the heart muscle. It will go to where blood is going, and it will not go, it will be a negative shadow if there was no blood supply or inadequate blood supply. So it helps you, its specificity improves, sensitivity improves with every increasing modality that you use. So like I said, ECG is limited, stress ECG is giving you more information. Stress echo along with stress ECG will give you the next level of information, and thallium scan will give you a perfusion.
Sorry for interruption.
So if there is a perfusion deficit, it helps you to identify the area where the perfusion deficit is, and also it helps you to quantify the level of ischemia. In other words, what is the muscle mass in jeopardy? If you say in a territory of LAD, there was not enough isotope traced in the anterior wall, you will also know how much of the deficit is there, and you can then say the amount of muscle in jeopardy is high, medium, or low, and you can decide on that basis the treatment to give. Now, recently, I won't say recently, but for the last 5 decades, there is an addition to that, and that is MRI. So you can do an MRI to identify perfusion. You can use MRI to identify fibrous tissue in the heart muscle, which helps you also very much in patients who have arrhythmias. If you have arrhythmias, it will tell you where whether there is a lot of fibrosis in the heart muscle from which an arrhythmia may be originating. So when we go to the rhythm part of it, we have basically the age-old Holter 24-hour Holter monitor, which will record your ECG for 24 hours, and we can analyze it to see whether there are any extra beats, whether there are any runs of arrhythmia, whether there is any heart block, or all these things can be diagnosed. So the electrical system can be diagnosed by 24-hour Holter, but in those 24 hours, you may not experience those events which are already existing, so you may miss it. So then we have the extended Holter, which we call ELR, where we can record for a week, and now there are devices which can record for 3 weeks remotely also. So that is the next tool for the electrical system. So what are you seeing? One, you are looking at the health of the heart muscle. Second, you are looking at the health of the electrical system, the His bundle, the AV junction. You can tell all this stuff. Okay. Then the third is to say, what is the actual perfusion by direct and indirect diagnostics? Okay. So you're saying now we very easily, and I'll give you the background. When we had a puzzling problem of, especially in women, where they complain of chest pain, but we have not been able to diagnose it with any other modality, when we have exhausted all other non-invasive modalities, they used to have to go for an angiogram, that is a catheter-based angiography. A catheter-based angiography is invasive. But since the advent of CT angio, where today we are up to 256 slice CT, which is very, very accurate, actually diagnosing by injecting the dye in the vein, and you can take the full image of the coronary arteries. It is a very so screening.
Sorry to interrupt, sir. I request everyone to please mute your mics. We have reached a moment. Please mute your mics.
So
Yes, sir.
when you have a CT image, CT angio image, it will give you a decent idea of what is the anatomy of the different arteries. But one thing is the limitation is that it will not tell you accurately what is the degree of the stenosis. It will tell you in a ballpark figure, in the sense that if it is 60%, it may tell you it's 50 or it's 70%, maybe even a little more variance. So if the trigger point is that somebody gets a CT angio and everything is normal, you say, okay, you can feel comfortable that your chest pain or other symptoms are not coming from lack of blood supply to your heart. So this is the additional test that you do in addition to all the non-invasive tests that I told you about. Then we say, if there is a minimum level of or below 50% stenosis, and none of the other tests were positive, like the stress test or the stress echo or the thallium, then we would say we will use this tool for treatment. And you say, okay, you already have the beginning of heart disease. We shall now put you on a progressive reversal of heart disease program. And that is quite effective if we catch it early enough. So the value of this tool is that, one, it will give you the diagnostics in a gross way, but also give you the opportunity to identify early coronary artery disease so that you can actually effect a reversal of heart disease program immediately. If the patient is cooperative, it is quite effective. If they will actually watch their diet, exercise, and the associated medicines that you need to give, you can effectively control the progression of the disease, and in some cases, you can even reverse the disease. Then comes the gold standard. The gold standard still today basically is the catheter-based angiography, which gives you a dynamic image of the three main arteries. So starting from the left main, LAD, circumflex, and the right territories, you will get a detailed map a roadmap of where, if any disease is there, if it is there, you can accurately measure the degree of the disease, and you can also decide what is the right treatment for it. If it is like, again, I said, if the lesions are below 70%, you may have, and the thallium scan is normal, you have an opportunity to treat this patient medically and try to control the progression of the disease or even reverse it. On the other hand, if the blockages are multiple and over 75% and showing signs of ischemia, then treatment will have to be instituted. And the treatment modalities are, like you said, if medicines are not the right choice because the disease has progressed to a level where you are actually at a high risk of getting an MI or loss of life, then what we say is either we treat it with angioplasty or by surgery, depending on the degree of the blockages, the location of the blockages, the length of the blockages, and multiplicity of the blockages. So if there are multiple blockages, those are the patients who veer towards coronary bypass surgery, and the ones who have limited short lesions, maybe 1 or 2 or 3 in the right location, they are good candidates for angioplasty. Then, of course, comes a subgroup of patients whose arteries are so diffusely diseased that they are neither suitable for angioplasty nor for surgery. Then for them, we use the modality, what we call EECP. It's enhanced external counterpulsation, where we pump the legs to provide a counterpulsation to the heart, and that develops the micro circulation in the heart. It helps to develop that and can be the only relief somebody has when there is diffuse disease, which otherwise is not possible by surgical intervention. So that's the spectrum of, grossly spectrum of how the diagnostics and treatment of heart disease dovetail into each other.
Thank you, sir. So with growing economic instabilities as well as increasing heart problems.
Can you speak a little louder, please? Because
yes, sir, sure, sir. With growing economic instabilities as well as increasing heart problems, what are the most pocket-friendly cardiac imaging technique for patients who can't afford them?
So I think the first screening would be a treadmill test. If somebody who has a cardiac history or some chest pain or something, and you want to demystify it, the simplest and the cheapest is a ECG followed by, if you find on ECG that there is evidence of an MI already, or there are some other abnormalities, that is one way of moving forward. The other way is to do a dynamic ECG. That is the most effective and the cheapest way of doing it. Then, of course, if somebody's on an ECG shows damage, echo is the other modality which will tell you what is the wall motion like. Is there damage to the heart muscle? How much? In what location? And then you can decide whether to proceed further with angiography or not. So it's true that today economic conditions may limit, but now there's this Ayushman scheme. There are many other schemes, ECHS, ESIC. So a lot of people will fall into this under these schemes, and they can access healthcare, including cardiology, including their diagnosis, including their treatment, which is a big thing. You know, the Ayushman Bharat has given succor to many people who were outside of the healthcare net. So I think that most people can be accessed, and BPL patients also can be accessed, and we all accept those schemes. And so there's nobody today who should suffer because they were not able to be diagnosed or treated properly.
Thank you, sir. Sir, are there any successful imaging techniques that are yet to be introduced in India? If yes, why haven't they been brought up yet?
You know, India, in cardiology, India is pretty much in tune with the rest of the world. And good thing is that our knowledge of cardiology generally in our cardiologists is quite superior, very comparable to the rest of the world. Like I worked in the US for 20 years, so I know the difference between what their capabilities are and what the capabilities of our cardiologists and cardiac surgeons is. So I don't see any major difference. You can use different isotopes because rubidium is manufactured in the US and Canada, so rubidium is used instead of thallium, but they are equal in many ways, maybe just 19-20% difference. So we are pretty much up to date. We can do almost everything there is to do, including all the techniques of intervention, but we are way ahead of the Western world in heart surgery. We do a lot more minimal invasive surgery and we do a lot more off-pump bypass surgery. Like in my practice, we do 99% of my coronary bypass surgery, total arterial and off-pump. That is much better than what most people are practicing in the US. So Indian facilities are quite good, very good in fact. And in my own lifetime,
We are having some problem in connection. I request IT team to please look into the matter.
Abhinay ma'am, I think this is just a technical issue. Sir needs to log in again.
Okay, ma'am. Okay. We will be sending him link again. He will join us shortly.
Naresh sir will be joining in a while. Meanwhile, this is for all the attendees who can hear and see us. The program is digitally sponsored by Clearnet. So I would like to share a glimpse of Clearnet and what is it all about. Let me share my screen. We are just waiting for Naresh sir to join again. So this is just a 1-minute clipping.
I guess sir joined us.
hello.
Yes, sir.
Sir has joined.
Thank you for introductory video, ma'am. Sir joined us.
So over to Naresh sir.
Sir.
Give me a minute, I will call sir.
Sure, ma'am.
So he is trying to join, I can see.
Okay, we have sir now.
Okay, sorry about that. So I was
Okay.
saying that you guys are the future of India. Okay, these are the young. The future of healthcare will depend on you guys. And I want you to take one belief, and I was giving an example of that. That we in India have been blessed with brains superior than anybody in the world. This is my belief because I've been there all over the world. I have worked there, trained there, competed with them. So I know, and you know already, how Indians around the world have done extremely well in medicine. In fact, 17% of all super specialists in the United States are Indians, and 11% are heading their departments. So you know that there is huge amount of currency we have blessed to us already as our brains. Now we have to put in some of the other things. So I was trying to say that, look, in my own lifetime, people used to come to New York for their surgery when I was there because there was no bypass surgery there. People used to come there. Now Americans are coming to me here for their bypass surgery and their surgeries. So this is a whole reversal in one go. So you all should look up. The main thing is what we lack is that unending commitment to excellence. If you are bitten by the excellence bug, you will, no doubt in my mind, rise to the top of the world. Because I said all the raw material is here, inside here. But how we utilize it, with what commitment we utilize it, and with what unending obsession of saying that we are going to be excellent and we will actually be ahead of the rest of the world in healthcare. Many, many opportunities today for all of us. One, to be excellent in your own way, and you can get training anywhere. But with what dedication and commitment you actually pursue that training, you will see that knowledge will come to you more and more. You will be trained better. Everybody will try to give you the best. So that's one part of it. I just wanted to share with you. So there is no real gap between the world and us as far as our ability is concerned. Yes, we don't have the ecosystem for doing basic sciences. We don't have the industry to develop new drugs and spend that much money in being able to be on the frontier. Although we have a very good pharmaceutical industry, but they are copycats. So we have to change our country from copycats to dictating our own destiny. And our destiny will come from your generation. Our generation has done what it could. We have created a platform for you. How high you spring from them, it depends on you guys. So I see you guys are from UP, right? UP Medical Association of Students. So some of you must be from my alma mater,
Yes,
also KGMC or KGMU now. I'll tell you. So you no matter what opinion you have of your medical education, I'll tell you we get a superior medical education in India than anybody in the world is getting. Now, how you go transform that is going to be your choice. So what happened to me? Why did I go to the US? If I take a minute just to tell you. We used to be sitting in KGMU night after night as medical students, knowing very well that patients had mitral stenosis, which led to cirrhosis, which led to ascites. In those days, I have to tell you how primitive things were. We used to put a catheter from the peritoneum into the internal jugular to transfuse the acidic fluid back into the body because we didn't have proteins to give. So we were using acidic fluid to infuse back into the patients. And obviously, we couldn't do anything. We could not operate on them. We couldn't do anything at that time. So we would see them dying in front of us after night of doing this pump. We used to just rotate that pump for 4-hour shifts and just pump the acidic fluid back. Then what happened? Then if you read the journals, you realize that there were treatments already being practiced in the United States. That's the reason why, out of that frustration, I said, we must go and learn and come back and bring it to our own people. That is the beginning of my journey. The rest is history, how I came back and all that. So I think that you people, as at the very vantage point, I can only look back. You guys have all your life to look forward to. So use this opportunity to actually pursue your passion and do it. Then don't be mediocre. To me, mediocrity is a crime. Don't look right or left. Just go pursue, if it is your true passion, to be the best doctor no matter what specialty. It doesn't matter what specialty you are. But if you decide that I'm going to be the best, you will be the best. And I don't want to give you like too many more lectures. I'm just saying I want to use this opportunity to communicate to you that the future is great. We are going through a very difficult time right now with this pandemic. Everything looks bleak, including the danger to ourselves. But it's all going to pass. We have seen these challenges before. They are temporary sort of reminders from nature or from God to say, re-look at your lives, readjust your priorities, and look forward to your life in a way which you think will be more constructive, will be more human-friendly, will be more nature-friendly. Because today, Tom Friedman, who's a very famous writer for New York Times, described it the other day as saying, this pandemic is a war between Mother Nature and Father Greed. So if we pay attention to both, we will be a better humanity going forward.
Great words, sir. Thank you so much. For last surgery arena, all of us would like to know, every surgeon has a moment where he struggles to save his or her patient's life. Hope might bleak, but he is determined not to lose the battle. Is there any such memorable surgery you ever came across? What challenges did you face at that moment? And how did the best cardiac surgeon, the best doctor tackle them? Sir.
So I'm not sure all of it is true, but what I can tell you that when I came back to India, my only message to our doctors, because I created Scott's Heart Institute, cardiac surgery was at a very nascent stage, so there was this new standard we created. And my only message to them was that there was, and I don't know if you've heard about it, that there was a movement known as Chipko movement in Madhya Pradesh. This movement was by Adivasis who were fighting against timber logging, that people were deforesting their whole environment. So these people used to stick to the tree, just chipko to the tree to prevent the lumber companies from destroying the forest. So, and they saved the forests by this movement. So my message to my doctors were, and I practiced it myself, you just chipko to the patient. Don't let him slip out of your hands. That's the best you can do. And if you treat every patient as a relative of yours, if you think it's your relative, you will give them the best. So if you thought it was your mother, father, brother, sister, whatever, you will not shy away from giving your best to that patient. And you must have untiring stamina to keep going in your mission to save every patient you can. There's nothing more gratifying in this world. You can be the most successful businessman. You may be very moneyed, but you don't have that satisfaction which we have, that you can actually save people's life. It's a God's gift to us. Now the only thing is that you should not develop doubts about it's too much hard work, not being paid enough. You're right. All those things are right. The challenges to doctors are huge. Every day we face these challenges. Every day somebody will come at you. But you are also the strongest person in society. You are the most knowledgeable person in society, and you are the most sincere person in society. So ultimately it will be okay. Don't get deterred by temporary obstacles or challenges that you may come across. And when you ask me this question, what patient do you remember? That's an everyday struggle. As a heart surgeon, you're taking patients with more and more risk, with more and more morbidities, with more and more ejection fractions of 10-15%. But you have to give them, you plan it properly, you execute it properly, and don't let it slip out of your hands. If you do it with that dedication, I can tell you, today patients who were considered inoperable, today we can operate on them with 97% success. People who needed heart transplants, over 95% of them will not need a transplant. So there are many, many things that have been accomplished. But it's a progression. It doesn't happen in one day. It's a lifelong work. I remember I graduated from King George's in 1968. And now it is what? 52 years later, or whatever, 50 years, whatever, I've lost count, sorry. So, yeah, it's 52 years. So it's a lifetime's work. You'll also be, hopefully, every time you stop, you look back, you'll say you've accomplished a lot. So, lesson is you're blessed. Doctors are, till today, treated with a lot of respect. There are many, many bad people who mistreat doctors, and yet there has become a lot of change because it's become transactional. You will be well off. If you have an MBBS behind your name, you'll never starve. But over a period of time, if you become excellent, people will break the door down to come and meet you. You don't have to worry about money. Money will come automatically. So I always say, good medicine makes good money. Good money does not make good medicine. So please live by that philosophy and you'll be successful in life. That's what I can say to you now, with a lot of conviction.
Thank you so much, sir. Chipko to patient, I and all our attendees nationwide take it as a note. Thank you, sir, for sharing your views. This session is honor for me, an opportunity to learn. There were very important points you mentioned. We would like to move to our next topic. Jay Pasi will be continuing from here. Jay?
Thank you, Abhinya. Those were some brilliant questions that were answered in a yet more gracious way. Good afternoon, sir. My name is Jay Pasi and I shall be carrying this interview with you ahead. First of all, I would like to express that it's an honor for me to interview you and it's like a dream come true. Sir, as we all know, this pandemic has shown us some worst times in the history of human civilization. For the economically challenged section of our society, it's quite hard to afford healthcare services as many have lost their jobs or any other source of income. The health sector also mostly accounts for out-of-pocket expenditure. What challenges do you think are mostly faced by the population due to lack of affordable healthcare?
So this is a very good question, but it deserves a long answer also because you've rolled many questions into one. So, okay, what the pandemic has caused. Now, in living memory, of course, we have not seen something like this. What had happened was the Spanish flu 100 years ago, but we can read history and learn from it. Spanish flu happened at a time where healthcare facilities were sorely lacking. It was like, again, what I told you earlier, that was a war between Mother Nature and greed. Means that there were too many people who were very poor and there were some people who were extremely rich. And the living conditions were not that great. They were pretty bad and it spread and it killed 50 million people or so, or 500 million. I think it's 500 million people around the world. Today, fortunately, we are faced with a challenge where our understanding of disease, viruses, our ability to fight it and prevent it is also there. In spite of that, this invisible little bug has created havoc around the world. So where will it end? Nobody knows right now. All we know is that there are ways of us controlling it, diagnosing it in time, and as time has progressed, we have understood the pathophysiology of the attack. Okay. So we know from the very beginning that our first attempt is to block the virus from multiplying. Second is when it is actually gone beyond that stage, to use high intensity antivirals as effectively as we can. And then in the meantime, some good antivirals have been sort of produced, so that we have remdesivir, we have favipiravir. So we have some reliable antivirals which will, used at the right time, will produce a lower response, multiplicity of the virus, and hopefully contain the disease. Then we know, if you've gone beyond that, that there is what we call a cytokine storm. And that cytokine storm is, of course, our own body's response. And we know how to blunt that so that it does not destroy the tissue. With this, 50 autopsies done in Italy, in Bergamo, actually showed us that the modality of death is not primarily from lung destruction. That this hypoxia is not only from the lung tissue being damaged, but it is from the thrombosis of the arterioles and venules that come into the lung for exchange of oxygen. So if the disseminated intravascular coagulopathy occurs, that you can get total hypoxia and hence death. So today we know that we try to contain the cytokine storm so that inflammation becomes less, and dexamethasone and TCZ, that's an experimental drug, are what we are using right now to try to blunt the effect. Then we have anticoagulants to try to prevent thrombosis. So our understanding of the disease and our ability to try to mitigate it is better today than it was maybe 6-8 weeks ago. Now we know that there is no cure, there is no magic bullet, but the whole hope is resting on vaccine. Vaccine, there are reports that it's advancing pretty well. Fortunately, there are Indian companies like the Serum Institute that has also been licensed to work with the Cambridge group, so that if this is an effective medicine, the vaccine, then large number of doses can be produced in India, because Serum Institute is the largest producer of vaccine in the world. So it may become available to us very quickly at an affordable price. Now, remdesivir is being manufactured in India by 4 companies under license from Gilead. That medicine is on the market now. And it is now at a cost of about 5,000 a vial. And for a treatment, you need about 12 vials. So 60,000 rupees is quite a bit of money, but still it may help hugely in saving lives. So I think right now, one part is that we have to try to control it, and we've always talked about the 3 mantras of distancing, masking, and hand hygiene. That if we can actually, the whole population accepts the idea and is not careless, and young and old should be equally serious about it, then we can try to control it as much as we can. Second is, there should be no stigma to it. People feel stigmatized, like you've got some venereal disease or something. It's not that. It's a virus which anybody can call. Any flu is like that. So the point is, you should not try to hide it. You should face it and isolate yourself. And 95% of the people are getting better off very quickly. It's the last 5-10% which we have to worry about. And that is the one that today's understanding of the disease has enabled us to save many, many lives. People from ventilators also that are now improving, which is a good thing. So I think that overall, this has taken a huge toll. Lockdown has taken a huge toll, but lockdown helped. There is a lot of controversy on TV. You hear about lockdown, or whether it's good, bad, or medium. In my opinion, it was essential because it gave us breathing room to develop our healthcare structure better. We now have enough ventilators and beds and PPEs and all that stuff, which we didn't have 3 months ago. So it was a good thing that lockdown happened. And in the meantime, also, like I told you, these drugs didn't exist. So if somebody got sick 3 months ago, 2 months ago, all these things that I told you about did not exist. Even the knowledge of it didn't exist. So that's why I'm saying that lockdown has helped to delay the peak. the spike is happening right now. And you can see it happened in Maharashtra, it's happening in Delhi right now, and it will happen other places also. And this comfort that you may have that it's not happening in my area may or may not be true, because what seemed like a good place is now becoming the worst place. So you take Chennai, you take Bangalore. Bangalore was always boasting that we are the best controlled. Now they are suffering. So huge number, it's going to spread, no question. And we will have to go through July. I think hopefully by the end of July, it will have peaked and started coming down. That's one part. Now, what is the economic impact of it? How do we survive? It is an unprecedented economical sort of burden on everybody. I'll give you the example of we are one of the most successful hospitals. We are today losing about 25 crores a month. The doctors have agreed to taking less salary. I'm not taking a salary for the last 2 months. This will be the third month. I will not. So we are all contributing to try to save the system. Now, there is the other problem is right now that we are treating COVID patients in one block of our hospital, which is separated from the rest of the hospital. But two things are happening. One, the cost of treating a COVID patient is high, and the government, and for rightfully to protect the public, has given the rates which are unrealistic. But we will have to treat them. We will agree. We will lose more money. But hopefully in the next 2-3 months, we shall recover. So healthcare will be one of the first things to recover once this pandemic ebbs. But in the meantime, there has been a lot of loss of life in non-COVID patients who couldn't access healthcare. That's the other challenge to our healthcare system. That though people who got heart attacks, they couldn't get to the hospital, they were getting angina, they would normally come to the hospital but were scared or could not travel because of lockdown. So many bad things also happened in the meantime. But given as it may, we are a young country. You are the future. We will survive and we will come out stronger. In the meantime, I think the only thing we can do is that the privileged should please take care of and be sensitive to the underprivileged, so that nobody should starve in the meantime, nobody should suffer lack of medicine. So we need to take care of them, because they are the ones who are miserable. We still have enough food on the table. So I think that we should consider ourselves privileged in the way that we are the ones who are okay and will be okay. But you look at the unemployment, those guys who are unemployed, they don't even know when the employment will come. So a lot of sensitivity towards them. Whatever we can contribute, we should contribute and try to save for the future. Now, it will pass. Whether it takes 2 months, 3 months, 6 months, nobody knows. But I think the worst will get over in the next 60 days. This is my, if I may take a guess, educated guess. So does that satisfy your question, or is there anything left?
Yes, sir. Yes, sir. That surely satisfies my question. So moving on next. In these times, we have seen that the health sector itself is economically drowning. Lack of beds and equipments has caused a wave of healthcare professionals pointing fingers at the government. What do you think should be the next step of the government towards helping in uplifting this sector?
You know, I'll tell you one thing, that it's a very tough task for a country like India, which doesn't have too much reserves and too many poor people. Okay. So who should we take care of? In the limited resources, who should we take care of? Okay. So the government has been responsive to the people so that food can get shelter, they can be, there was a little trap here because in the lockdown, people got trapped. So there are all these debates which we shouldn't get into. But what we need to get into is the fact that in the health sector, we said we want only 2 things from the government. One was that the government agencies like CGHS, ECHS and all, they owe the hospitals a lot of money. that if those payments could be made, it will help us to survive. To some degree, it has happened, but not to the degree that it should have happened. So a little bit came and then it didn't come and then it's gone into a little bit of a spin. Second thing we said was we have to borrow money to survive. Like we are borrowing, even in Medanta where we are as strong as we are. And we are giving up our salaries and stuff like that. That please give us those loans at a lower interest rates. So that the burden becomes a little less and we'll pay back. We're not asking for grants. We're not asking for dole. We're not asking for free money. We're just saying, just help us to bridge over this gap. So far, like I said, there has been a partial response in payment of dues from CGHS, ECHS. But there hasn't been any response from the banking part of it, which would help that the doctors and especially small nursing homes and all, for them to survive on a shoestring has become a problem. To afford PPEs and N95 masks has become a problem. So I don't know, hopefully the government at some point will realize that the healthcare system, private healthcare system is sinking and that it can be given a little bit of help, no grants, nothing, just a little. How much does it cost to give a loan, a bank loan from 10%, bringing down to 5%? It will help a lot for the person who's borrowing, but it won't damage the banking system. So we are still hoping, we are still demanding all that. But right now we have been a little bit of a ignored child, you can say.
Thank you, sir. Moving forward.
Like I will come back to the point.
Yes, sir.
We are the strongest in society. We shall survive. In spite of my disappointment with not getting all this, we will survive because we are fighters. We fight for life every day, for everybody. The moment we give up our spirit, the country will go down. We are saying, yes, it's difficult. There is some insensitivity towards the healthcare system. Hopefully, it'll happen soon. If it doesn't happen, we'll see. We'll still survive.
Thank you, sir. Now moving further, as I have read and I have heard, Medanta not only treats but trains and innovates too, while providing international standards of technology, infrastructure, clinical care, and a fusion of traditional Indian and modern medicine, all at 1/10 of the cost. So now, we all would like to know what all challenges you faced during your journey, especially financially, and how did you deal with it along with the competition that you faced all along the way?
You know, I'll tell you, there is no real plan or genius. Anybody who says I'm a genius, it's not true. Okay, anybody who claims they are geniuses, they're not. This is a set of circumstances and your thought process being alive all the time that you latch on to what you believe in. Like I told you, my journey started from that 4-hour turning the bedside of seeing a patient die, putting the peritoneal fluid into the vein, right? My journey started from there. As I said, the education at King George's is probably the best as good as anywhere. But in spite of that, there was such a lack of, in those days, there was such a lack of technology, knowledge, ability to do things. That frustrated me enough that I said, have to go, I can't practice medicine like this. The same will be true for you today. We are way ahead, but we are still, this is a dynamic field. It keeps improving. There are newer and newer things. We are at biomolecular level. Everything will become biomedical. There will be AI everywhere. There will be robotics everywhere. I mean, I brought the first robot into this country in 2000. So we've been doing heart surgery, now urology, all the other technology. But when you come to research, we've done a lot of work on trying to integrate modern medicine with traditional medicine. As we speak, we have a very big study going on against COVID, combining the treatments together. So this is now coming to an end, but we have done a lot of work on neurology, on rheumatoid, on cardiology, in combining these therapies. So there in fact, we have a Ayurveda hospital inside our hospital. So it's a daily event. So a lot of work is being done. We are doing a study on TCZ, which is an anti-inflammatory. Right now, the study is going on. We have done a lot of development. We have some devices we are developing. So yes, research is alive and kicking. We have a collaboration with Duke University, what we call Medanta-The Research Institute. So a lot of work is going on, developing vaccines. So the things are in motion, and any one of you, whoever wants to come and visit, most welcome. Let this Sankraman get over, and then just call and come. You're most welcome.
Sure, sir. I will do within Medanta.
I think our time is up, isn't it? If there is a pressing question, please ask.
I would like to hand over the mic, the baton to my colleague Harsh Rai. That's all from my side, sir. Thank you. It's been an honor for me.
No, my pleasure and honor too.
Thank you so much, Jay, and a very good afternoon, sir. Sir, it's an honor to be with you. Sir, since emotions are produced in brain, but they often hit us in heart. Broken heart syndrome is a real thing, as there is a well-established connection between mental health issues and heart diseases. Medically, the term is acute stress-induced cardiomyopathy. It occurs due to the surge of stress hormones affecting the heart, typically after a traumatic life event like divorce, domestic abuse, public speaking, and any major setback in life. You may feel sudden and intense chest pain. It is often misdiagnosed as heart attack, but there are no blocked coronary arteries. It's not always fatal, but can lead to serious complications like heart failure. Sir, so if a person dies of stress cardiomyopathy with an ongoing illness like cancer, etc., how do the doctor diagnose and what do they put up as the cause of death?
So you started with a very nice subject.
Thank you, sir.
Matters of the heart, which you guys are in that age group where the flutter of the heart still happens when you get, interaction, excited, all that stuff. And that's what you should be doing. You should be enjoying every part of life. And that's what I actually wanted to stress on, that every part or stage of life has its own responsibilities and opportunities and pleasures. So you should actually experience them, all of them. Never lose your youth or your whatever, right? So this is the time of joy. I mean, you still have problems, you'll still have anxieties, but those anxieties will stay with you for life. I mean, at every stage there is an anxiety. I mean, right now there is a blackmailer behind me who's trying to blackmail me. So that, these are things, they never end. Okay. So the basic thing is not to be deterred, because like I said, जिसको आत्मविश्वास डॉक्टर का सबसे ज्यादा होना चाहिए, because you have to communicate it to the rest of the people.
Yes, sir.
If you are wobbly and you're treating somebody, they'll get wobbly automatically. So you always have a responsibility. You look at it. From ancient times when Hippocratic Oath was written, doctors had no medicines, nothing. All they did was go sit by the bedside of the patient, feel his pulse, and reassure him that he was going to get better. And 90% of the time, they would get better on their own. That was the ability of the body. But that very vital role that a doctor played in the mind of a patient to give him hope is what made them better. So one thing is that no matter what's going on in your mind, you are to project hope. You are to project optimism. You are to say, look, this is the person. And I'll give you a very interesting incident. I'll take 2-3 minutes.
Yes, sir.
There is an organization which is Gita oriented. Okay. And they asked me this was from the ramparts of Redford. There were 5,000 sort of pundits, or you can say Vidwans of Gita who were assembled, and they asked me to speak about medicine and Gita.
Yes.
I had never read the Gita, but I do have paraphrase, paras from Gita I've heard from my grandparents and then myself and whatever. So I did some research. So Gita, goes back between Krishna and Arjuna. That's all there is to it in Gita for those who haven't read it. So in the discourse, Arjuna is treating, Krishna is treating Arjuna because of his mental fears of how he could go to battle with his own family. He is described, when I read this, I took out 5 things for me. One was the fact that when a patient comes to you, he is not only coming with his disease. He is coming to you with a whole mental load, which is whether I will get better, what will happen to my family, how much money is going to cost, and will I ever be the same? Right?
Yes.
Now, when a patient comes to you, our response or our training is, look, ask him, Raj, kahan dard hota hai, kahan ye hota hai, kahan ye hota hai, ye dawai le lo. But you did not address the rest of his 4 problems. You just addressed one.
Yes.
So you did not give him that comfort that, look, you address how it will be, give him hope, give him that he'll be okay, and also that the family should also feel that hope so that he doesn't feel the burden on the family. Now, you don't want to give him totally false hope, but you want to give him a measured hope depending on. So in the given circumstances, you actually measure what is the right message to give to him. And you need to give him only 2-3 minutes to download on you. But never be in a rush to say, उसने 4 लफ्ज़ बोले तो आपने diagnosis लिखना शुरू कर दिया. Listen to him for 2 minutes. He will also feel the comfort that you have connected. The moment he knows you have connected, 50% of his disease is over already. So that's the kind of communication that I learned. That yes, there is a whole bandar of problems on a patient. He's got all these fears, all this responsibility, all this insecurity. If you answer all 3,
Yes, sir.
you have become a superior doctor, and your patients will feel much more connected with you. Today, what is the pitfall? That we say, चलो 500 रुपया दिया उसने, 2 मिनट में उसका लिख के उसको नुस्खा लिख के दे दो, चले जाओ भैया. Then it is a transaction. It is not medicine. You must understand the difference between a transaction and a medicine. Medicine is connect, feel, and then treat. Those are 3 things, mantras you must have in your dealings every day. You don't just become kitne patient hai bahar lao, fatapat lao, and it doesn't take time. I see more patients than anybody of you right now. But you learn that you need to treat the whole patient and the family, not just his chest pain.
Yes, sir.
Get my point? Okay. So can I take your leave now?
Yes, sir. Sir, concluding, sir, we have written a poem for you. I would like to recite. When there was darkness, you emulated light. When there was ignorance, you imparted education. When there was hopelessness, you became a living hope. To the unsung hero, to the soldier of our breath, to the God sent from heaven, to the backbone of Indo-Canadian architect Medanta, to the outgrown fruit of King George Medical College, we are lucky to have you here. To the man awarded with Padma Shri and Padma Bhushan, to the patriotic soul bringing knowledge from the worldwide, to the doctor challenging cardiological challenges, all of your glories, all of your knowledge, all of your hard work, all of your sincerity, we salute you, sir. Thank you so much. It was really mesmerizing having you on the panel in the first place, sir. As of now, we are at loss of words how fascinated we are by your knowledge, wisdom, as well as your simplicity. We still can't believe that we were lucky enough to have this session with you. You are a pioneer in medical field, and we all are blessed to have your footstep to follow. We thank you again for taking out your precious time for us, sir. It has been really, really amazing
I
experience
want
for
to say
us.
something.
Thank you so much. Yes.
First
Yes,
of
sir.
all, I see 5 other people on the screen.
Yes.
Of course,
Yes.
Harsh, I see you. Give me your introduction.
Sir, I am a third year medical student, sir.
Where?
Sir, National Medical College, sir.
Okay.
Birganj, Nepal. Yes.
Okay. And then I see Abhinya. Abhinya?
Good afternoon, sir. Sir, I am Abhinya Srivastav, third semester student from Heritage Institute of Medical Science, Varanasi.
Okay. And then I see Rajneesh Rai.
Yes, sir. Yes, sir. Sir, I am an intern in Heritage Institute of Medical Science, Varanasi.
Okay. So you're very serious. You should lighten up a little bit. I didn't see you smile throughout that 1 hour. Okay, so Rahul.
Yes, sir. Good afternoon, sir. Myself, an intern in Santosh Medical College, Ghaziabad.
Okay. And Jay.
Good afternoon, sir. My name is Jay Pasi, and I am a second year, fourth semester student from Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. And sir, it's my pleasure that I share the same university as you, KGMU.
Okay. So my honor. I really enjoyed it because this is time well spent because you, like I said, you guys are the future. Just hold up the flag, and
yes,
I'm sure you guys will do very well and keep India at top of the world.
Thank you.
All the best.
Thank you so much.
Thank you.
Sir, now also I would like to thank our National President for IMA MSN Dr. Arvind Swamy sir and National General Secretary Dr. Simran Kalra ma'am. Also Dr. Rajneesh Raj sir, IMA MSN UP State President, and Dr. Rahul Anand sir, IMA MSN UP State General Secretary, for making this possible. Furthermore, I would like to thank our state co-conveners Dr. Shreyas Raj and Dr. Navya Jain, and our state joint secretaries Dr. Rakshit Gupta, Sakshi Singh, Lakhan Prakash Gupta, and Rohit Maurya for having our backs. I would also like to thank my team of Stethify, the official podcast of IMA MSN UP, Isne Sahani ma'am, Jay Pasi, Abhin Srivastav, Arijit Bansal, and Harsh Rai, that's me, sir, for their hard work, motivation, and constant support in making this event a grand success. Sir, we're really honored to have you here, sir. We're at loss of words.
Thank you, sir.
Thank you so much for joining.
I enjoyed it. I don't know. I think I enjoyed it more than you guys. All the best. Thank you.
Thank you so much, sir.
Anytime.
Good afternoon, sir.
Anytime. Okay.
Okay, so thank you all on behalf of Team Clearnet for the wonderful session. Thank you so much for all your support. Thank you.
Thank you, ma'am.
So we are good to close the session now?
Yes, ma'am.
Yes,
Okay, thank you. Thank you so much.
Thank you so much, ma'am.
Thank you.
Thank you for all the attendees. Thank you so much for joining in. We are closing the session here. Thank you.